The advanced imaging fellows need to be in the first row. They'll be grilling and quiz. You heard that right, Dr. Yang? Dr. Senapati? Including the chief fellow. All right, today we're going to talk about coronary CTA, advantage, and pitfall. I changed quite significantly my talk this year. Don't want to show you the same thing. Obviously, you get bored. So I'm going to make it a little bit more interactive this time, especially toward the end. Okay? Right, advantage. Well, the main advantage of coronary CTA is I think this year I can be quite confident and quite without much hesitation that coronary CTA really is becoming the one-stop shop for assessment of coronary disease. Any disagreement from MRI people? No, I guess not. All right. The reason is simple. We can assess the luminous stenosis. We can assess the plaque. We can look at the perfusion. We can look at the function, including wall motion and functional significance of stenosis that we see, all in one single study. I'm sorry?
You could do viability too.
That's less well studied, but we put it up there, but eventually we'll get there. Okay, and the main advantage, I think this is mainly a summary of what Dr. Nabi showed in his introductory talk. All this technical quality of CTA make it really the to-go technology for assessment of coronary disease. Okay. First, obviously, we can see the anatomy. We can see the plaque through a non-contrast CT. And coronary calcium score, you heard a lot, is one of the major prognostic factors in patients with or without coronary disease. And with the administration of contrast, we can see the luminous stenosis. That's obviously what the major reason why our doctors order the CTA. But also, we can look at the plaques. And there's more and more work, obviously, in terms of prognosis and character of the patient with coronary disease determined by the plaque morphology and volume. And you're going to see more of this coming out. I'm not going to spend too much time talking about because this is obviously by itself a separate, a whole lecture. But I think for the fellows who read CTA with us, this is very important, okay? We not only be able to look at the coronary stenosis, the plaque, the distribution of the vessel. Very important for you to pay attention to the heart outside the coronary tree. Okay. This question goes for Alpana. What do you see here? What this image here help you to decide if the coronary artery is normal or abnormal before you even look at, is this normal finding here, right here in the apex?
No. It looks like there may be either some sort of calcification or
correct. Yeah. So number one is a little bit thinner. Yes, okay. So this per se is a very important finding, especially if you have a study with not so good quality. Same here, okay, this is the fat infiltration. It's very typical after myocardial infarction. And in some extreme cases, instead of fat infiltration, you get heterotropic calcification, like here, in patient with extensive anterior MI. Okay, Dr. Yang, what is this?
Looks like a pseudoaneurysm.
Yes, it's a pseudoaneurysm. With a, so, okay, the echo was able to see that too, but here, obviously, patient come with acute coronary syndrome. You have a occluded OM stent. Okay, so me perfectly, you can see the coronary and the consequences of the acute coronary syndrome all in one single study. Okay, who else? Man. Where is Man? Not here? I thought he was here.
You were pointing at food.
Oh, okay. Other advanced imaging fellow. who has done CT? Prem, your turn. What do you see here? This one. What's abnormality? VSD, yes. And how do you know if it's due to coronary event or not? You see the apex here, right? It's thin now, it's a little bit less perfusion, okay? And obviously, sometimes you can see this patient with wall motion abnormality and a clot there, okay? So basically, so all this you can be seen in the CT. So when you order a coronary CTA, again, don't pay attention to the coronary trees only. Actually, you should look at the rest of the heart first before you look at the coronary. And obviously, CTA is a to-go technology for assessment of coronary anomaly, like this patient with single coronary, patient with Alcapa, patient with, we've seen so many cases, coronary anomaly, and usually refer even after a cardiac catheterization, invasive angiogram. But I think this is a very important application for coronary evaluation, especially now we have a very robust adult congenital program. This is a 16 years old girl who has single ventricle, I believe, already had 2 coronary implantation, okay? She has minimal exertional angina with minimal exertion, and her heart rate is very high, okay? So she had a study done in Texas Children's Hospital with a 320 slice scanner, supposedly, and the image quality was okay, but they did a retrospective gating without dose modulation, giving her 30 millisievert of radiation, okay? And obviously, we weren't gonna do the same thing because of the scanner we have. We took advantage of the superb temporal resolution and dual source. Because her heart rate was so fast, we couldn't do the flash scan, so we did prospective gating, and we ended up giving her about 4 to 5 millisievert, and you can see that she has critical stenosis of the ostium of the left main, where the implantation is. Notice it's very different from arteriosclerosis, right? I mean, she doesn't really have coronary disease because of her age, and this is all just post-surgical changes. Again, application for coronary anomaly or post-surgical changes in adult congenital patient is becoming one of the most, CT is becoming one of the most useful technology because now we can administer very little radiation, and the key factor is real quick. All these tests could be performed in less than a minute. And not only that, I mean, occasionally, we do these interesting cases. We can apply 4D CT. The only application I can come out with is like this patient with myocardial breach. Obviously, you can see clearly during systole the mid LAD is being squeezed here. So just for fun, not terribly useful. Okay, and again, this is one more, this is the reason why I'm stating with more confidence now this coronary CTA is a one-stop shop because now we are able to perform physiology, okay? We can look at the physiological significance of a stenosis either using myocardial perfusion imaging, either regular static qualitative perfusion, basically just look at, each segment of myocardium have more or less contrast, or this is mostly still in research in terms of dynamic perfusion imaging using CT. Specifically, you can be, with this, you will need a top-of-the-line scanner, like 256, 320 detector CT or dual source CT with shutter mode will be able, allow you to do myocardial perfusion. And obviously, we're gonna hear more in the future about CT-FFR will provide you the functional significance of the stenosis. Again, per se, a separate talk, so I'm not gonna do it with it. All right, this is some example of advantage of CT, someone coming in the emergency room, acute chest pain, dyspnea exertion, really, in old days, we do, stress tests and rule out MI, and here quickly you can perform this study even before you have the troponin back. Ideally, you want to wait for the troponin, but you can have this quick diagnosis, corroborated with subsequent angiogram with very tight proximal LAD disease. But the most powerful quality of coronary CTA is to rule out presence of coronary disease. Not only presence of coronary stenosis, but presence of any coronary disease, okay? So essentially, a normal CTA, 98, 99% power of excluding presence of CAD. This is, you know, this is the coronary trees that we all want to have. So how good it is, coronary CTA, in terms of diagnosing degree of stenosis? This is probably the summary of 3 largest multi-center study. I'm sorry, got cut off here, but the key I want you to pay attention is mostly the negative predictive value is very high, but the positive predictive value is a moderate because presence of coronary disease calcification tends to make us overestimate amount degree of stenosis because of the blooming artifact. Okay, so we talk about. I show you a bunch of beautiful images. You know what CT can perform and achieve and accomplish, can deliver, but life is not perfect. Always has some troubles, and that's why we need to recognize the pitfalls of coronary CTA to know this. To know the limitation. Okay, is my arm back? All right. I'm gonna have, let's see, Dr. Yang. How many artifacts you see here in this side? Do us the best you can.
So I see breathing artifact.
Breathing artifact. How do you know it's breathing?
Chest wall, or movement artifact. Chest wall movement, the ribs are.
Slightly off.
Yeah, like,
Okay, I'll give you that. So there's motion, right? Patient motion.
there's a beam hardening artifact.
From?
From instantly.
Okay, good. So this is the beam hardening artifact he was talking about, okay? You see, because the photon has different, because the X-ray has different energy, okay? So only, for instance, here, it goes through the very dense objects, so those with the lower energy doesn't go through this, therefore give you shadow like this, okay? So that's a beam hardening artifact. Okay, what else?
There's a stitch artifact.
Stitch artifact. Let me see if I can, it means like here. Okay, so like this. So step artifact, stitch artifact, and that's due to?
Due to the fact that the sternum has to move between each block. This is probably maybe a 64. Like less, it can't cover the whole heart in one.
Correct. Because the whole heart, usually the coverage you want at least 12 to 16 centimeter coverage. And depending on the scanner, most of the 64 slices only covers 4 centimeter. Our dual source cover about 6 centimeters. So unless you have 320 or 256 or 520 slice scanner, whatever they advertise, you're gonna have step artifact, okay? And that's usually due to slight changes in the heart rate, correct? So that's mostly due to cardiac motion, right? Anything else?
Similar to beam hardening, you have calcium moving artifact.
Okay, so what he means is right here, good, very good. You have 5. Let's push you a little bit more. That's almost level 1.5. Okay? 2.5, I'm sorry. If you get me
I will consult my co-fellows.
if you get
who
if,
may
if you
know.
get 2 more, you level 3. Level 3. No?
We are stumped.
Just the image quality. How is it? Does it look
Oh
nice?
yeah, no, it's grainy.
It's
There's
horrible.
Less,
Yeah,
less
right?
signal. Yeah,
Noise, right?
exactly.
Usually due to either not enough contrast. Here it's hard to tell. Probably timing, because I'm kind of seeing the vein, okay, SVC having contrast and the rest of the heart doesn't. So it could be due to timing problem, but I'm not gonna Okay, it could be patient body habitus. How about this? This is the same sets of images.
That's
This is original raw images coming out of the scanner. This is done touched by the technician. He did something. What do you think here, this strip here? Look even worse, right, than original, right? So usually this means there's loss of data, okay? So what happened, this patient has some irregular heartbeat, slightly irregular heartbeat. The technician thought it was a PVC. So he decided to edit he decided to take the sets of data corresponding to that beat, okay? And since the patient's heart rate wasn't that fast, that leads to the loss of the data, okay? So so anyway, so you can, in a study, you can find a lot of these artifacts. For you, it's important for you to recognize, and before you could have, for instance, this coronary arteries here, going through this stitch artifact, you could have a little gap. You might think is a significant lesion, but it's not, okay? So motion real quickly, sometimes it's hard to notice during just looking at actual images, but this is so significant, the motion. You can notice a little jump right there, for instance, okay? And then, let me see, right there again. So this motion most likely is due to patient emotion, as you can see here. This is almost uninterpretable. You can tell it's cardiac patient's motion because, again, there's a movement of sternum, okay? Okay, so this is just another example. Cardiac motion. Cardiac motion is mostly due to the slight irregularity of the cardiac rhythm, and because coronary trees move throughout the cardiac cycle. As you can see here, this is the same study, same patient, same study in different part of the cardiac cycle. You can see the right coronary is much more blurry compared to this. I believe this is doing diastole, this is doing systole. So that's why it's important to have our current neuroscanner allows you to have padding during prospective scanning. If you do retrospective scanning, you can have multiple part of the cardiac cycle, which allows you to find the phase with least motion. But because of prospective gating has much less radiation exposure, but in the older scanner like the Philips 64 we can only get a single snapshot of 70, 75%, whatever you choose. But now newer scanner allows you to open the window a little bit, meaning that you can image from 70 to 80%, 65 to 75%, or you can image from the from the previous R wave. You can choose doing systole. You can either open the window for 100 milliseconds, 200 milliseconds, depending on the heart rate and the rhythm. So it's for you very important to know what the patient's heart rate and rhythm is to choose how much you want to open that window. Kind of have to find the balance between the radiation exposure and possibility of finding a good phase which allows you to see the coronary artery. This is another example. Patient's heart rate is not so irregular. You can see between 96 and 100 and average of 98. So in the old scanner, I would say we'll probably never be able to do prospective gating because chance of finding one single moment in the cardiac cycle to have all the coronary segments perfectly frozen is almost impossible. Okay, so a newer scanner, we could use, for instance, a prospective gating, again, doing systole or doing diastole. As you can see here, very different. The top panel, I think, is doing different, and the lower panel, and the middle panel, they correspond to a different part of the cardiac cycle. One is completely uninterpretable, and the other part is perfectly interpretable, okay? This is a very interesting case that I just run across by doing a very specific study a patient who come in that we decided to do a flash scan with flash mode for us, for a fellow who haven't done CT. Our scanner is special because we have two source, which allow us to real quick scan. We can do the scan in 275 to 300 millisecond. Scanner can go very fast, cover entire heart in 1/3 of the cardiac cycle mostly. So we decided to do the patient, this protocol, caudal cranial, bottom from diaphragm toward the head. And immediately afterward, we come down again, cranial caudal, and we come back up again, caudal cranial. So it's total, same patient. His heart rate was very good, quite stable, in the 50, I think between 58 and 62, I believe. Same, almost similar heart rate. So this first one is caudal cranial. This is cranial caudal, this is caudal cranial again. You can see the RCA is look completely different, okay? And that tells you exactly how coronaries are so sensitive to cardiac motion, okay? Even the patient with slow heart rate, okay? Because the timing of the cardiac cycle in which I image these segments is same as this one, but different from this one. And you understand a little bit better what that means. So this is how our dual source CT with high pitch flash mode work. So patient go through the tables slow first, and then when the heart get into the field of view, you accelerate, okay? So the table move about 87 centimeter per second. So you do the math, essentially to cover our 16 centimeter, we only need 270 millisecond to cover entire heart. So notice that even the image looks quick. You see, not all the image are done at the same part of the cardiac cycle, as you can see right here, okay? So that's why it's not the same going this way or this way. Okay. This is another interesting case. Looks like this patient had, motion, right? Looks like patient had, it's almost impossible to have 3 vessels going on. You know, RCA is only 1 RCA. You can't have 3 RCA. Okay, so it was surprising because patient heart rate was very stable. As happens, the patient had very, obviously, kinky RCA, I guess, which really very important point. You know, radiology by training, they look at actual images. So they just go down slice by slice, and if you look at this, and you call this artifact. But for us, you know, especially in this lab, I know you guys probably never look at the actual images. The first thing you jump in and just to start, you know, tracing the arteries. So kind of the other extreme. And study has shown that best diagnostic accuracy for interpretation of the coronary artery is a combination of interpretation of the actual images and NPR, okay? So for you, this is, so I call that a pseudo artifact. Contrast timing is very important. We show you the slides with artifact. This is what you want, okay? For coronary evaluation, most of the contrast in the left side, ideally nothing in the right side, because RCA is located right next to the right chamber. If you have too much contrast in the right side, sometimes can have interference. I'll show you an example of it. So this is what you want. This is acceptable, okay? And probably for a certain condition, like you want RV function, for instance, this will be enough for you to look at both left-sided structure, coronary trees, and the right-sided, okay? And triple phase injection, very important for our congenital patient. Most of the time we want to know the right ventricular function as well. So essentially, you inject contrast, bolus of contrast, follow to opacify the left side, followed by a combination mixture of saline and contrast to opacify the right side, and then followed by a chaser of saline. So we call it triple phase injection to achieve opacification of both right and left side. So this is an example, for instance, of too much contrast in the right side, okay? And sometimes you can have this strict artifact coming from too much contrast, which you see that all the time, some remnant of contrast in the SVC causing strict artifact could interfere with your interpretation, especially of the bypass graft and right coronary arteries. Okay, so this is the most important part of the talk for the fellow, okay? What's the degree of stenosis? All right, that's what the referring doctor wants to know. Okay, so you need to know, this is part when we have to, be honest to ourselves, how good is CTA, even quantitative CTA, in assessing accurately degree of stenosis compared to QCA, meaning quantitative coronary, invasive coronary angiography. Okay, I'm going to skip this one. This is a classic paper that established how good we really are in assessing degree of stenosis. So all these patients had obviously invasive angiogram. It took a long time for them to do this study, obviously a lot of measurement. So essentially you can see the degree of stenosis of CT versus invasive angiogram, okay? I mean, it's good correlation, no question about it, but a lot of scatter, right? So only, a coefficient only 0.76, and this is the key. The mean difference percentage stenosis, 1.3 plus 14.2, so essentially confidence interval is plus minus 25 to 30%. So what does that mean? If I call a stenosis 50%, could be 25, in 95% of the confidence interval could be 25% or 75%. Two confidence interval would be extreme would be zero would be 25 to 80%. Okay, so that's why we should never report a stenosis to the degree of 45, 55, even 50 or 60%, because we know that's far away from the real stenosis. And that's why the Society of CT recommend that we grade the stenosis this way, okay? Normal, basically no plaque, no luminous stenosis. In this case, a good quality study, you can be very confident in saying this is a normal. And minimal will be plaque with less than 25% stenosis. Again, mild, 25 to 49, 50 to 69, so on and so forth, okay? So it's very important for you to understand when you tell the referring doctor a degree of stenosis, you need to explain it well in terms of what is the limitation of CTA in quantifying degree of stenosis. Okay. Okay. Calcification, we all know very well the presence of calcification affect negatively the accuracy of coronary CTA. We all heard this example before. This question before is any threshold of coronary calcium score to hold the contrast part, okay? First, let's learn how to read the calcified vessel. So this is the image of the patient, LAD with a lot of calcification. Kind of doesn't know if there's a stenosis here. First you do is to adjust the window, basically widen the window so you can get rid of some of the blooming artifact, or you can do sharp filter, okay, and sharp filter eliminates some of the consequences again, or you do combination of both, so you agree that this is a little bit easier to read than this one. So first, we need to learn how to read the calcified vessel. This is a case that we just did a week ago. A referral from a Herman Memorial Hospital cardiology in West Houston. He referred this patient, 95 years old, with some atypical chest pain and some abnormal stress test, okay? Calcium score 2,300, all right? Actually, patient wasn't done here, which I call him, obviously. This morning I say, if you have a patient like this in the future, you might want to send the patient here. So patient ended up in Methodist West Houston, which we have a G64 slide scanner. It's like a Toyota Corolla, all right, compared to a Porsche that we have. It works, it gets you where you want to, all right? And actually, I would say, I know you all complain about West Houston not doing a good job. I mean, you know, this is not bad, right? This is not bad study, right? Considering degree of calcification, and this is after adjusting all the windows, sharp filter, blah, 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 using all this vessel. So right is very small, non-dominant, LAD has disease, and, you know, is it 75, you know, it's all moderate, you know. Is it significant here? But the key is, you know, I think we don't know exactly, patient had a functional test, supposedly inferior lateral ischemia. Okay, it's true or not? So we send it to CTFFR. And the vessel who showed up,
Can you go back?
yeah,
And the one, the second from the left,
this one,
you know, the hypoattenuated areas between, yes, well, I mean,
this,
how can you say that there's no thrombus, there's no soft plaque? You
well,
know,
patient is stable, you know, it's outpatient.
understand that.
Yeah, it's not easy, no.
I may not have a patient in front of me.
Yeah, no, I agree. This is very, you can argue some of this could be, some of it could be motion, okay? So you can go ahead and take the pain and measuring the attenuation coefficient unit to see, it could be, you know, soft plaque, could be artifact.
Now, the question to you is, how do you navigate that? You understand what I mean? How do you, if I see this,
Usually,
where do I
if,
go by? Because sending it to an FFR may be the same problem that you start. with.
correct. You know, we think CTFR is a panacea. But the point what I want to go to is, you could argue, okay, this patient has symptoms, and, you know, the stress test is equivocal, if you want to say. But I think for management standpoint, I think it's useful because, you know, guy is 95, not very symptomatic, doesn't have left main, proximal, we think he doesn't have any significant, this is the left main right here, it will be a proximal LAD, probably still okay. This is proximal, this area, I think in other projection looks better. You can argue probably is okay, you can manage the patient medically. It's not easy, especially you don't have the best, you know, scanner with the best technology.
Would a Porsche help navigate this
With
rocky
what?
road?
I'm sorry?
Would a Porsche help navigate this rocky road? You know, I mean, if you had, right? Meaning if you had the dual thing, I mean, would be less problematic, significantly less problematic?
Could be. We don't know until we do the study, but there's some software, supposedly you can subtract the calciums, but again, not terribly well validated. But this is not unusual. We encounter, you know, especially when we read the TAVR study, right? This is almost like the TAVR patient that we read. I think obviously for clinical trial, you would not want to do patient, you know, like this if you want to study the diagnostic accuracy per vessels. But for clinical management, I believe personally, depending on the clinical picture, degree of stenosis, degree of calcification probably is not a contraindication to perform a study, I think, personally. For instance, this case, you know, like this, with this degree of calcification, it's impossible to see if there's significant stenosis, and I don't believe CTFR will work too well either. But, you know, if you can look at, again, right, remember, I told you earlier, look at the other part of the heart. If you have this finding, you know, this artery, LAD is diseased. So, you know, if the question is the patient need to go to cardiac catheterization, I think the study is helpful. Yeah.
Can I ask a question? I think
Sure.
this is a relevant one. I don't know if it's known in the literature, but if I look at this CT angio on the right side, I mean, are there any studies to tell me that if either the conglomerate of the, meaning as opposed to diffuseness, small, mild calcium, either the location or the intensity of the diffuseness, something like this to conceivably alert the clinician, don't push the imager to say something beyond which I should not do a CTA. I could stop there and ask for something else.
You mean from the non-contrast scan?
You got it?
Yeah. The question, I think, is now, I think when we started doing coronary, we have Dr. Moa's opinion, but I think that when we started doing coronary CTA, we used to also do calcium score as well. But now almost nobody does calcium score anymore because, mostly, I think because of additional radiation you get, because in the big picture, in the old days with the retrospective gating, you get 20, 25 millisievert, you add another 3 millisievert, okay, 25 versus 28. Now we're doing flash scan with less than 1 millisievert, or most of the time perspective with 3 millisievert. Adding another 3 millisievert sounds a little bit excessive. And the calcium score, what happened when we do the calcium score, the thickness we use is 3 millimeters. So if you see a lot of calcium, sometimes you cannot tell if it's concentric, eggshells, or circumferential. Let's put it this way. Unless you do really thin slices, calcium score, which again, you increase the radiation. So we know from the location of calcium matter. We know from the plaque imaging that dense calcification has different prognosis than mixed calcification, and microcalcification probably the worst. But those would not be able to, at this current stage, cannot be evaluated with non-contrast CT. So, Moaz, do you have any? I know you've done quite a few work on this, so. But in our lab, we don't turn down coronary CTA.
My view is, like, at least what I do in my practice is that I still do calcium score before CT. And the reason for that, yes, I agree that there are calcium scores that are done with DLPs and 150. But if you have a flash right now, you can easily do it with the DLP between 30 to 60. So the flash calcium score, it does help me determine my Z-axis, so I will save eventually in the contrast. And I published on that it does add in symptomatic patients, which is the most of the population, it does add incremental prognostic value over. So my practice is that if I see a lot of calcium, I stop there and send them to perfusion imaging, whether you want to do it with, because even if you look at these studies, when they looked at, you showed Gilrath paper. So Gilrath did a very nice analysis in that paper where he did look at the diagnostic accuracy by the calcium score. And your negative predictive value dips down to the mid-80s or even like 70s when your calcium scores start to become very high. So even if I see something there and I'm sure that I could pan it out, and now in the era of CT-FFR, I'm sure, there is still that hesitancy that, yeah, I might be missing. CT-FFR is not a 100% test. So there's still, so when you have a calcium score which is like in the 1500 or 1000, yes, you can spend long time and at that time potentially say, okay, I cleared every segment, or there is that diagonal that I cannot clear, but I still feel it's not the ideal test when you have other good perfusion studies, whether you want to do it with CT, you want to do it with MRI, you want to do it with nuclear imaging, specifically PET in these patients. I feel it does add incremental value.
I agree completely. I think, for diffuse dense calcifications, I think perfusion studies. But, in terms of, if you want to know if the patient has stenosis, depending on the clinical question, it's hard to, in practice, you get a referral from a doctor to do a test, unless it's completely contraindicated for safety reason. It's hard to send the patient out. Yeah.
Two follow-up questions. Two follow-up questions. One is, in the experience since we had, the dual scanner, how many non-diagnostic tests have we had? Meaning there are areas where I really couldn't see because of heavy calcifications I can't see. So, one, we have to be honest with ourselves as to how often does that happen, right? If it happens 0%, I would be a little concerned.
No.
Right? So
It's
that's
not- it's
one.
not
And
0%.
two is conceivably, one of our fellows could do a research on if I have so much calcifications and maybe another test was done just to look at the accuracy of detecting ischemia or stenosis or something like this. I think that's important because I agree with Muaz. At some point in time, we have to say, hey, this may not be the most appropriate because we have so many other testing that we could do on a particular patient.
Correct.
And stop and say, this may not be the most appropriate test for you, and we probably should do either a PET or a stress test or some other things to tell us about disease.
I completely agree. I think we kind of go case by case base. Someone who had 900 calcium, 1,000, and heart rate is 90, I probably would never do that. But if the heart rate is nice and slow, 50s, I'll take my chance. I mean, depending on the clinical question. But now we have PET, I think, it's tremendous opportunity.
Presume that the size of the blooming artifact for calcium is less as you have higher resolution?
Higher resolution, and also heart rate is probably more important. The cardiac motion tremendously magnify the blooming artifact caused by the calcium. So if you have especially with the newer, I think Toshiba has now 0.25 thickness scanner detector. You can give enough energy, and if you have a slow heart rate, I believe most of the coronary segments, more than 1.5 millimeter segment, could be evaluated adequately. But again, we don't have the technology. Yeah. Okay, so real quick about stent. This is, we also use nice example of stent, but also it's easy to diagnose occluded stents as well. The tough one, cases like this. I'm not gonna, the stent is probably open. It's impossible to know if there's in-stent restenosis or not. Okay, so the current at this stage evaluation stent, which we get that all the time, and that's one of the other sticking referral issues. Do we go ahead and go ahead and do it, or we tell the physician, say the currently stent evaluation, unless they are more than 3.5 millimeter stent, the result is diagnostic accuracy is not that good. And this will be another area of study with the PET will be probably more, PET or perfusion imaging will be more useful. So again, similar for reading, interpretation standpoint, similar concept. You do sharp filter, windowing, and remember, for very calcified lesion and stent, 3D imaging is not useful at all. Okay, this is, I think, with Dr. Alpeshah doing a lot of CTO, this is becoming a more important question. When you see a total occluded vessel, okay, just I want you to pause this, for a second. Think about the image we see, right? We give about 50, 70 cc of contrast through the vein, all right? And you're able to see the image what we see. For the fellow who has gone to the cath lab, how does the coronary look like when you give 50 cc of contrast in the aorta? Anybody? Fahim?
That's all.
Dr. Not great. Just think about it for a second. Instead of giving if you're injecting directly from the aorta, a power injection, all right, same amount of contrast, you can barely see any coronary. We're giving the same amount of contrast from the vein, and we can see the coronary tree, not perfectly, but reasonably well, okay? So that's why, coronary CTA is so powerful. That's probably the major advantage of CT because of that point and because of the technology. CTA is different from fluoroscopy. But the key is for patients who have total occlusion, when you inject intravenously, you can have distal, the vessel distal to the occlusion with good filling, and with collaterals sometimes. And when you do the direct intraarterial injection and you floor the patient, sometimes you don't see you might not be able to see the collateral. That's why we get the referral from surgeon and interventional cardiology all the time to say, hey, this vessel is occluded. Can you look at if there's any collaterals and distal fillings, okay? The main issue here is also CT is not very good, we know, in differentiating between total occlusion versus subtotal occlusion. They could look very similar, okay? They all have distal filling. That doesn't mean, total occlusion doesn't mean you don't have any filling afterward, all right? And it carries significant therapeutic implication because the subtotal occlusion, the treatment of choice is PCI, right? And CTO, chronic total occlusion, is more controversial. This is just want to show you some examples of actually, this is a patient with a dyspnea exertion, abnormal myocardial perfusion imaging, and you can see that very diseased vessels, and in the middle here is an interruption of the arteries. And if you look at the coronary, the coronary lumen, the attenuation, distally, you can see what we call transluminal gradient actually is kind of reversed, meaning that the distal part of the vessel is higher or similar to the more proximal part of the vessel. The segment nose is occluded downstream from the occlusion. So made you think maybe this vessel is being filled by collaterals, okay? It's being blood flow is coming this way. Compared to this case, is actually Dr. Chamsey's patient, also a patient with total occlusion, okay? But looks like occlusion, but was this subtotal or total? But here, as you can see, the transluminal gradient maintained, meaning that actually the gradient decreased along the vessel. So it's kind of opposite of what we saw in earlier, okay? So here the gradient go down toward the distal vessel versus the prior cases. The distal portion of the arteries actually has a similar or even a little bit higher attenuation contrast compared to the more proximal portion of this part of the arteries. Okay, so this probably, if I have to guess, I would say this is subtotal, and patient probably will be PCI would be relatively easier compared to this case. Okay, and this is just an illustration of the comparison between total occlusion and subtotal occlusion. Usually, subtotal has a little bit lumen here, usually shorter segments of occlusion, and the transradial gradient is slightly different. And this is just a little bit, is for more advanced fellow who there's some of the characteristic that allows you to differentiate between subtotal occlusion from total occlusion. Okay, do we have time? No? 5 minutes? All right, Alpana, Dr. Yang, you can work together. There's three, okay, I'm sorry. There's 3 EKG here. Which of these 3 EKG is this patient have? Okay, so I'll give you, so this is AFib, right? This is sinus, and this is AFib also. And this is, again, I'm going to show, the study is pretty good. It's a diagnostic test. So when we used to have Philips 64 scanner, we will never do coronary artery CTA, coronary CTA with this rhythm. The first one and the third one, okay? Number 1 is very fast, very irregular. Now, almost is not an issue anymore. We might not be able to see 100% of segments, but we can see the majority of segments, especially the proximal segment. Okay, so what do you think? Can you tell from this study is AFib or not?
Honestly, from the study, you can't tell if it's AFib or not, in my opinion.
With the old scanner, you'll be able to tell because it's really irregular. Remember we said earlier, you're going to have a lot of stepped artifact, right? Because, your imaging, each time you go around the heart, you're looking at different part of the cardiac cycle because it's so irregular, right? This one could be fall into systole, diastole, like this one is very different, okay?
So I think it's pretty clear, like the images. So it's either prospectively acquired, like in the sinus, like it's captured in systole, and this question is, is it AFib or is it in sinus?
So it's captured in systole or diastole?
So the,
The aortic valve
The-
is
yeah.
closed there, so
It's
probably
not
captured in that.
I don't know if it's completely closed or about to close, but it's not. It's
The
not
mitral
fully
valve
open.
is slightly open,
Yeah, that's true.
okay? And, thickness of the myocardium looks okay. Normalish, doesn't look systolic, so this is diastolic imaging, right? And I show you here, there's a clot, this is a left atrial appendage. Clue here is left atrial appendage, so most likely patient has AFib. So this is the EKG. I mean, this is not, usually we do it opposite. Well, it's important for you to know, what, the exercise should be the opposite. I give you an EKG, you tell me which scan, which type of scan parameter you use, all right? But this is just for fun. So last, I want to show you two cases, okay? They're all patient in their 50s. One done with our scan in West Houston with the GE. One done here with our dual source scanner. Okay, over 50s, they'll have, equivocal stress test. Okay, so what do you see here, Dr. Yang? What do you think about image quality? The technician called me, both of them, the heart rate in their 50s.
So there's quite a bit of step artifact you can see between the slices in the.
Okay,
and
so
maybe
what
in
do you expect the
corner here.
EKG? What?
So I would expect the EKG to be irregular in this case.
Irregular, okay. So probably not, bad. So this is the EKG. Okay, it was slow, but it's irregular. See, this is very important. That's another concept. Slow doesn't mean everything's fine. It's probably either PAC. I think the P wave looks, it could be sinus arrhythmia. You can see, this beat is really the one who caused most of the, okay, that's what caused a step artifact right there, right? So you can see the blurriness, okay? And this is done here with our scanner. We do, so by the way, with the G scanner, we cannot do flash mode, so we did prospective gating, all right? 75% cardiac cycle. So this is done with flash mode, okay? I mean, the image quality, they're both normal. But I want you to pay attention because the difference is scanner, the radiation dosage the patient received, all right? So our GE scanner only do 120 kV, so that doesn't allow you to do lower kV imaging. The patient could be small enough for you to do lower kV. So the DLP total he got was 467. That's equivalent of roughly 6-7 millisievert, right? And with flash mode, compared to prospective gating, on top of it, we were able to perform 100 kV imaging. Look at the DLP that we got. Oh, right here. $39. So more than 10 times less. Less than 10% of radiation dosage, right? So 39 versus 400 something. And you cannot never tell from the pictures that one patient received less than 10% of radiation compared to the other. So anyway, so our final thoughts is we want to have patients have a good heart rate. We want to use the best scanner, best imaging protocol, be aware of the artifact. And again, we'll talk about a lot. Care for patient selection, very important when you want to have a good CT lab and provide the best service for your patient. Okay, that's all I have.